Hi, my name is Jerry Hesch, and I'm going to demonstrate a very quick, very cursory knee eval. This client injured her left knee stepping off a ladder and twisting today. And I've screened her knee already, and I do not suspect a torn medial meniscus. Did a McMurray's test, and that was negative. Now, she could have a small tear that we can't find clinically, and that is a possibility. I think what happened was I think that the patella subluxed laterally because she has a fair amount of medial joint line pain. Now, she also has a little more hyperextension on this left knee than she does on the right knee. Now, I'm going to show you a drawer test on her right knee, and I don't get much movement. Maybe I get a millimeter, maybe a little more slightly. On this knee, it's very obvious that she definitely has some play there. So I suspect some laxity in the anterior cruciate ligament, but that's an old injury to my understanding. She can perform a half squat, at which point she gets pain. She has pain with sitting when the knee is flexed 90 degrees, and the pain again is primarily medial to the patella. It feels better when I soften that connective tissue. When I push the patella medially, it lessens that pain. She also has pain down the calf. There's no discoloration, and pain along the posterior tibialis muscle. And in palpating, I noted a definite temperature difference out in this lateral area overlying the fibular head. So after screening the knee and coming to the conclusions that I have, which is that she has an old ACL laxity and probably had a slight subluxation of the patella so that there is medial soft tissue pain, maybe a small tear of the meniscus, but I could not discern that with the McMurray's test. Pain with sitting, pain with the knee bent 90 degrees, and she can only perform a quarter squat. Let's demonstrate quad strength. Hold your knee totally straight, please, and don't let me bend it. Hold it totally straight. So she has pretty good quad strength. I can't break that. But what I did notice is that I tested foot and ankle strength, and I want to demonstrate to you strength of the peroneal muscle group, which is now called the fibularis muscle group. Pull your foot up and out like that and hold it really strong. Don't let me break it. And I'm not able to break that. And now on this side, pull it up and out. Don't let me break it. Okay? So what's up with that, client? It's weak, right? You can't hold it out there?
Right.
Okay. So this muscle is inhibited, the peroneal group, fibularis group on this side. And I checked the ankle, the foot and ankle, and didn't get any input here. Checked the fibula, checked mobility here. But when I come up here, I do find that this fibular head is more anterior, okay? And when I palpate behind it, I'm getting quite an expression on that face that we're not going to show you. So I'm assuming that means it hurts, and now I'm on the back of this. So how do these compare, left and right? Can you tell me how they compare? Are they the same? Is one more painful?
The left is more painful.
The left is more painful. Okay, so I'm going to submit to you that there is an anterior subluxation of the fibular head. And so we're going to stop filming. I'm going to treat it. I'm going to mobilize it in posterior glide. After that, I'm going to test the fibula and make sure that it is neither superior nor inferiorly displaced. If it is, I'll replace motion there. I will come back, we'll test her for tenderness here, and then I will test strength of the peroneal group. I would submit to you that when I reposition this fibula, and we're talking a subtle subluxation, perhaps on the order of 3 millimeters, maybe 4, that when I reposition it, that there will be less mechanoreceptor activity in the capsule and the ligaments in the portion that is stretched, which would be primarily the posterior aspect. And that by repositioning it, will remove an inhibitory influence on the fibularis muscle group. So we'll stop filming right now and then I'll do the treatment.